This podcast is brought to you by the Pharmacy Operations and the American Oncology Network, an alliance of physicians and experienced healthcare leaders working together to ensure the long-term success of community oncology. We are committed to deliver operational, clinical, and financial efficiency based on the most sustainable model, reshaping the future of community oncology practice. I'm your guest host, Melody Chang, the Vice President of Pharmacy Operations at Aon. I'm thrilled to announce the launch of our monthly pharmacy podcast, where we will explore a wide range of topics covered in our pharmacy newsletter. To listen to the podcast and to read the transcript, please visit the Pharmacy Operations Internet page. On today's episode, we will be delving into the critical issue of cancer drug shortages with a specific focus on navigating shortages in breast cancer treatment. I'm delighted to introduce our two outstanding guest speakers for our first episode. We have Dr. Stephen Fred Divers, Aon's Chief Medical Officer. Dr. Divers is a medical oncologist with Genesis Cancer and Blood Institute in Arkansas. He has provided physician leadership as a member of several national committees. He also currently serves on the board of directors for the Community Oncology Alliance, COA. Our second guest is Cassie Perkey, who serves as the clinical pharmacist for the Aon Central region, covering Arkansas, Indiana, Louisiana, Michigan, Ohio, and Texas. She also sits on the Aon Drug Shortage Committee. Cassie is the PGY2 trained, board-certified oncology pharmacist, and she joined the Aon team in March of this year. Welcome, Dr. Divers, and welcome, Cassie.
Thank you, Melody.
To set the stage, a recent survey conducted by the National Comprehensive Cancer Network revealed that 93% of the large cancer centers are experiencing a shortage of carboplatin, and 70% of the centers have reported a shortage in cisplatin. And we know both cisplatin and carboplatin are the old chemo drugs, and they're fairly inexpensive but widely used. And they're highly effective chemo treatment, often intended to cure a variety of cancers, including breast cancer, lung cancer, gynecologic cancer, GI cancer, bladder cancer, and head and neck cancer. So dealing with the drug shortages is a nightmare for almost every institution, especially if the shortage escalated to a national level. So Dr. Divers, as the Chief Medical Officer for Aon, I'd like to hear your take on this situation and how are you dealing with this at your own practice, Dr. Divers?
Thanks, Melody. Yes, I appreciate you bringing this situation to light. It's been a real issue and a challenge, not only for our oncology network, but throughout the country for other providers. The shortages of the platinum-based drugs have made a significant impact on, the quality of care that we're able to provide for patients, and created some real operational challenges and stressors. Prior to the platinum shortages, we had shortages of various other drugs. Typically, these are less expensive drugs made by a few suppliers. And then with the onset of COVID, inspection of certain factories or producers was delayed, and that in turn resulted in reduced production of the platinum drugs by a limited number of suppliers. That resulted in platinum shortages for oncology patients throughout the country. And so this was probably the first, crisis of the drug shortage that we've really had. I mean, the others that came before were very temporary We had a Taxol shortage, we've had heparin issues, we've had leucovorin issues, but the platinums were, I think, really the straw that broke the camel's back and said, hey, we really need to take a deep dive and look at what's causing these shortages and how do we intervene to prevent harm. For our network, I think last year we gave something like 16,000 doses of carboplatin and cisplatin to over 3,500 patients. And so, a shortage in that regard makes a significant impact. So we've set up P&T committees to monitor this. Our pharmacy team is monitoring all the drugs that are on allocation. But with respect to the platinum shortage specifically, it was a real challenge. And just to be frank, I had to send several patients home because we did not have their drugs. And that did result in delay in care for a number of patients. And so this was a real problem. We did bring it up during our visits to Washington, D.C., and it did create quite a stir there. Anytime you see patients' access to care being interfered with, I think our legislators take that very seriously. And so, I think COA and other organizations have made some suggestions on how to help along that front. But it was really just a perfect storm of the pandemic, limited number of suppliers, and then not being able to meet the need that's out there. So probably some of it has to do with the reimbursement of those drugs as well, and we could do a better job on that front.
Thank you, Dr. Divers. I know this is a very, very complex issues, and thank you for your excellent point. And I know you have treated many breast cancer patients. Given your extensive experience, could you share your insight into the significant impact of the shortages of drugs like carboplatin, cisplatin on the treatment options available for these patients?
Certainly. The breast cancer patients were really in the crosshairs here. And it's not all breast cancer patients, right? For those patients who had estrogen receptor positive tumors, the platinum drugs are not a mainstay in the adjuvant treatment or metastatic treatment of that disease process. So those patients were really spared the tragedy. But it was really the two cohorts of patients, which were the triple negative breast cancer patients who were estrogen receptor negative, progesterone negative, and HER2 negative, and also the subset of HER2 positive patients. Those were the groups that were most significantly impacted. And just to put that into some perspective, we have to keep in mind there's probably 275 to 300,000 breast cancer diagnoses in this country per year. And of those, about 10 to 20% will be triple negative breast cancer patients, and about 20% of those will be HER2 positive breast cancer patients. So you're really thinking about, 30 to 35, maybe 40% of that 275 to 300,000 patients, which is not a small number. You're talking about impacting, up to 100,000 patients who may have curable disease. And so the real issue is that the triple negative cohort of patients require intensive therapy with combination of an anthracycline, a cyclophosphamide, a platinum, a taxane, and an immuno-oncology drug, typically Keytruda, based on the Keynote study. So that rapidly became the standard of care. It was a challenge for the triple negative patients because you really have one option in the upfront setting to cure these people. And so you don't want to dose reduce or eliminate a portion of the therapy there. And truthfully, particularly those triple negative patients who have any problem with homologous recombination deficiency or loss of heterozygosity, i.e. that group of patients who have DNA repair deficiency, such as BRCA and other mutations that fall in that category, the platinums are a significantly important part of their treatment regimen. And so we took a population of patients who have very high risk, very lethal disease, but very curable with aggressive therapy, and then limited their opportunity to receive that therapy due to this drug shortage. And so we did reverse perhaps the order and maybe use the anthracycline and Cytoxan first while we waited on the platinum and taxane to become available. But this was a real, if I was a triple, and I did have to send a triple negative breast cancer patient who's originally of Mexican descent, who lives in this country, and I had to send her home and say, I don't have your drug. And it was eye-opening for me because she looked at me and she said, well, do you think I could get access to this if I went back to Mexico? And so boy, what a shocker, right? To think that we live in this country but can't provide the appropriate level of care for someone who may have to return to their native country to receive that care. But so that was a real shocker for me, and a turning point where I said, we got to do something with this. The other group of patients is those that are HER2 positive. And I think, for any of those patients who have higher risk disease, i.e. those patients who have a T2 lesion or greater, carboplatin is a standard part of platinum, docetaxel, trastuzumab, and pertuzumab. And so, those patients were impacted as well. That's another group of very high-risk breast cancer patients who have potentially curable disease in the adjuvant setting. And there's a real possibility with this drug cancer shortage that we could not really comply with the standard of care and meet their needs for definitive treatment and curative treatment of their disease. So those two patient populations in the breast cancer setting were significantly impacted. The other comment that I will make is this was really a shortage that adversely affected the females in general, because if you think about the GYN status, for GYN oncology drugs, platinums are the mainstay of therapy for every ovarian cancer and endometrial cancer and cervical cancer. And so the women were disproportionately affected by this shortage. And it's really a travesty that something like that could happen in this country today.
Well, thank you, Dr. Divers, for sharing your extensive knowledge. I think we all learn a lot on a daily basis, every day, working with you at a PNT, and you share those experience, how you treat the other disease. And obviously, I can imagine how challenging it must be to inform your patient that a particular drug is not available, and you have to do an alternative. I'm sure this will add to the stress of an already difficult situation. Cassie, as a regional clinical pharmacist, you have the opportunity to visit the clinics and assist our providers in managing various pharmaceutical challenges. Could you share some of the most common inquiries you received from the providers and describe how you help them navigate these situations?
Yes, thanks. That's a great question, Melody. So in regards to the platinum shortage, I think the most common type of question I've received is from a provider looking for alternatives to carboplatin or cisplatin for specific patient cases as they arise, of course, with the continual waxing and waning of the drug supply. I think, however, a lot of these patient-specific scenarios can be prevented with the organized efforts that AON has put forth with things like the drug shortage committee that I think Dr. Divers referred to earlier, and in our PNT committee. The drug shortage committee is multidisciplinary and brings representation from pharmacy operations, nursing, procurement, revenue cycle, all to implement strategies for shortage management, because it's here whether we like it or not. Some of the things that we implemented for the platinum shortage have been dose rounding strategies and creating a document of carboplatin and cisplatin alternatives that are organized by disease states, and especially with those that have the heaviest use of platinum, such as lung, head and neck, gynecologic cancers, like Dr. Divers was talking about, and of course, breast cancer. The committee also created a drug shortage dashboard to highlight the drug needs at a clinic level to help with allocating the supply that we did have or do have, and also encouraging providers to look ahead at their patients that are on platinums and have a plan B in place if a patient were to be affected by a complete out of stock situation. Communication, of course, is key during a shortage like this. So any major updates from the drug shortage committee are communicated across the network to providers, clinic managers, pharmacy staff, through emails or through our PNT committee updates and provider news. But those are some of the things I think need to be highlighted for at least what Aon has been able to do with the drug shortage and how we've been able to help as pharmacists.
Excellent. Thank you, Cassie, for providing the excellent insight. I know we're not completely over the hump yet, but at least we're making progress and making the situation manageable, especially if you highlight a very key point, the communications. How can we have a real time and communications to send those emails out to the providers, and then giving them the list of the patients that will be impacted so they can prepare. Thank you. Dr. Divers, as a chief medical officer overseeing the patient care during the drug shortages, and you also mentioned about you have to start difficult conversations with the patients, maybe giving the alternative treatment or send the patients to somewhere else, or even send patient home. And that's kind of a moral stress, I believe. It's going to happen during the drug shortage period of time. Can you share your thoughts on how healthcare providers cope with the moral stress of making tough treatment decisions, and what advice would you give to other providers?
Thanks, Melody. That's that's a difficult question. You never really want to be in a position where, in the setting of a limited supply, that you're forced to make rationing decisions, at least certainly not in this country, regarding patient care. And it is a tough conversation to have with the patient family, and certainly the dynamics of the cause of the shortage are complex and difficult for them to understand. I mean, I think my advice would be, it's not our individual faults, and we still feel guilty and bear some of the stress related to the absence of drug availability. But I think important points to keep in mind here would be, number one, reach out to your colleagues. I did have some colleagues at the university nearby who had some additional platinum drugs, and so we could move patients around and make sure that they had some available, or they could obtain access to the drugs there. So that's one option, is maintain your contacts with your colleagues, because as Cassie pointed out, the supply does wax and wane, and some sites may have some and some do not. We did that within Aon, redistributing supplies needed throughout the network. So I think maintaining that, contact with your colleagues and trying to ensure that patients get access. The other points to make would be, I think, use this as an opportunity to advocate for the patients as a whole. And, whether that be speaking with your congressperson and legislator to let them understand that this is a real issue and a problem, so that they can get some legislation through to help prevent this in the future. I think those are key. Obviously, spending time with the patients so that they understand we're doing everything that we can to make sure that they have access to care, and trying to keep the patient at the center of this discussion. So it does create a stress, and certainly in a busy day, if a patient is there and you don't have their drug and you have to adjust, I think, probably the best thing is to take a deep breath and count to 10 and make sure that the logistics within your clinic, are helping to arrange appropriate redistribution of drug supply and or adjustment of scheduling of patients and treatments accordingly. But we never really want to be put in a position where we have to choose one patient's fate over another. Obviously, we do tend to leverage curative intent above palliative intent, but outside of that, we're not in the business of picking winners and losers here, and we don't want to go down that path, and would rather have a solution to the problem rather than be forced into that issue. So it does provide stress, but I would say, we're not in this alone. And I think, fortunately with Aon, we have a great network of pharmacists and procurement team to help manage this. But it is clearly has been a challenge, and I don't, to your point, I don't think we're out of the water yet, but I do see, some brighter days ahead, now that this issue's been brought to light.
Yes, thank you, Dr. Divers. And your emphasis on the patient-centered care and the importance of maintaining the treatment continuity during the shortage is a message we can't stress enough. And thank you. And then as someone, Dr. Divers, someone who served on the board of directors for Community Oncology Alliance, COA, how do you see the current drug shortages affecting the oncology community at a national level, and what initiatives are being undertaken to address these issues?
So, I think it was a unifying theme for academia and community oncology and private practice and large, unified groups all suffered, the same stress that was induced by these drug shortages. And so I think it did bring oncology as a field together. We did Community Oncology Alliance organized a meeting in Washington, D.C. I and a number of my colleagues did go to the Hill. We spent an entire day on Capitol Hill visiting with our respective legislators. And when you go visit these folks, sometimes there's complete buy-in, sometimes they don't really understand the issue, sometimes there's an educational gap for them because maybe healthcare is not their focus, but there was almost a universal complete buy-in that this is an issue that must be addressed. And that was the point I was trying to make earlier, is that these guys really are very patient-centric congresspersons, and when patients' access to care is threatened, they tend to act. And so I do believe and anticipate that you'll see some action come out of Congress. There's another Hill Day, and we will again go back and visit with our legislators in September, and continue to drive home the point that this should be resolved. COA has put forth initiatives in the past to at least sort of guarantee the manufacturer a minimum margin on these drugs to ensure that you'll have an adequate number of providers available, right? So that if an inspection or an audit is delayed and the supply chain's interrupted for any reason, you have enough other suppliers in-house to maintain the distribution for the patients as a whole. So there are options, regarding the reimbursement side to help with that. The FDA, everybody, I think, questions what the FDA can and cannot do. They have sort of limited ability here outside of allowing other drugs. And I know they did lift some bans on or allow inclusion of drugs from China and India that were not previously allowed during the drug shortages. And so I think those are actions that can be taken by the government as a whole, but ultimately we would like to see this problem go away. This has gotten worse. It has not gotten better over the last 3 to 4 years. I think it started back with the leucovorin shortages maybe 7 or 8 years ago, but has continued to get worse. And so we want to create an incentive so suppliers will keep drug supply in the supply chain and in the market. And to do that, we need to make sure that there's adequate reimbursement on their side, to make sure they're whole, to make sure that inspections and audits are done in a timely fashion, and to make sure that the supply chain is diversified enough so that should there be some force majeure that happens in a certain part of the world, that the supply chain as a whole is not affected due to some ripple impact. So I think those are key points. I think our legislators do understand this, and we're going to continue to push the issue through COA and other initiatives. But for any other providers out there who struggle with this, I would say reach out to your congressperson and just let them know that this is a real problem. And in the absence of some intervention, this may continue to be an issue.
Thank you, Dr. Divers. It's fascinating, and I think it would be a great to explore this further in our future episode. I think we have a lot of information you can share with our audience, and then we can learn. And thank you very much for you and for COA, what you have been doing for the community oncology environment. So I think as we come into the end of our discussions, do Dr. Divers, you or Cassie, you have any last insights or takeaways you'd like to leave our audience with? I'll start with Cassie.
Thanks, Melody. I don't have anything more to add, but thank you again for having me on the podcast, and thanks, Dr. Divers, for all of your input.
Thank you. How about you, Dr. Divers?
Yeah, thanks, Melody. I think you did a nice job of this podcast addressing, the gravity of the issue and how many patients are really impacted by this, and how this is an issue that really, it takes a team and it takes a village to overcome. I mean, so a lot of it is based on education, and hopefully this podcast will assist in that. And as we provide alternative options and solutions for the healthcare providers out there, educate the patients on why these shortages do exist, and then educate our legislator and pharma partners on what we need to do and how we can be partners going forward to prevent those shortages in the future.
Thank you both for sharing your extensive knowledge on this complex issue. Your insights into this current landscape of cancer drug shortages are invaluable. And I'd like to thank our audience for listening. And Pharmacy Connect podcast is brought to you by Pharmacy Operations and the American Oncology Network. You can find and listen to all the podcast recordings on the Pharmacy Operations internet page. We hope you enjoyed this episode and see you all at the next one. Thank you. All right. That's all we have for today. Thank you, Dr. Divers. And
Thanks, Melody. That was
Cassie.
great. Thanks,
This is
Cassie. That was
awesome.
great.
Daryl is going to do some editing, and we will send the finals products to you before we push out to the network.
Awesome. Thanks, Daryl.
Thank you, Dr. Divers. Thank you.
And
Thanks,
thanks, Cassie, for
everybody.
highlighting, what all you guys do. I don't know. I mean, it's a tough job. I appreciate y'all. That's all I can say.
Oh, thank you.
Thank you.
Mhm.
All right. All right.
Bye,
Thank you.
everybody.
Bye-bye.
Bye.
Bye.